Comparatively, but the brain health is overlooked and misunderstood. A major new study shows that more than 3 billion people worldwide live with a neurological condition. Neurological conditions are the leading cause of poor health and disability globally. I would note parenthetically that my wife deals with a very rare disease that's known as Morvan's disease. It has to do with brain encephalitis. She's doing very well overcoming it, but it's everywhere. And it's not being, I don't think, adequately addressed on a global scale, at least by our government. As life expectancy grows and healthcare costs rise, policymakers must consider the looming health crisis of brain diseases and disorders, especially in low and middle income countries. I have introduced my bill, the Global Brain Health Bill, in Congress after Congress after Congress, and have not been able to get it passed, but I'm absolutely determined that in the next Congress, we will see it come to fruition. Take Alzheimer's disease. Alzheimer's is the most common form of dementia, usually affecting persons age 60 and older. As we all know, it's degenerative, irreversible, and a terminal disease that progressively corrodes the brain's memory, thinking, and reasoning skills. Currently, over 55 million people worldwide live with a form of dementia, and 60% of those are in developing countries. With life expectancy on the rise, a tsunami of Alzheimer's cases is on the global horizon. In 2011, when I chaired the very first congressional hearing on the topic of the global crisis of Alzheimer's disease, projections estimated that 80 million people would have Alzheimer's or another form of dementia by 2050. In 2017, the projection was revised to a whopping 115 million. Today, Alzheimer's Disease International estimates 139 million cases of dementia by 2050, and again, things are getting worse, not better. This increase will be felt more drastically in the low and middle income countries. As populations grow rapidly and life expectancy, good news story, lengthen. One recent study found that dementia cases in sub-Saharan Africa will grow by over 300%. Low and middle income countries will struggle to manage this health challenge due to a small and untrained health workforce and inadequate and inaccessible care. Little public awareness and health professional training on the signs and symptoms of Alzheimer's pose a challenge. A global study by Alzheimer's Disease International found that over 2/3 of people incorrectly think that Alzheimer's and other forms of dementia are just normal parts of aging. As the co-founder and co-chair of the Congressional Alzheimer's Task Force, Ed Markey and I formed it back in the year 2000. We have maintained for over a decade that the administrations of both parties must pay more careful attention to this mounting crisis. Yes, we have provided more money to NIH. There's been a quadrupling of funding for research, and that is absolutely welcome, but more needs to be done again on the international level. I also co-chair the Congressional Autism Caucus, which I founded in 1999, and I authored the Autism Statistics, Surveillance, Research, and Epidemiology Act, a bill to authorize grants and contracts for the collection, analysis, and reporting of data on autism and pervasive developmental disabilities, and established regional centers of excellence in autism and epidemiology. Passed as part of the Child Health Act in 2000, it was offered as an amendment by yours truly. This provided the basis for future iterations of autism legislation, including the Autism Cares Act. Earlier this year, the House passed my bill, H.R. 7213, the Autism Cares Act of 2024, and I'm happy to say, after it was blocked in the Senate, that block seems to have been lifted, and maybe as early as tonight, they may unanimously consent the bill. Both sides, through the hotline procedure, have agreed to it, so it will become law, and it is a substantial, not only reiteration of current policy and reauthorization, but an expansion as well. About 1 in 100 children around the world, it's estimated, have autism, a spectrum disorder marked by degrees of difficulty with social interaction and communication. While research and care for autism has improved in wealthier countries, such as the US, and including chronicling how many, it is seriously neglected in much of the developing world. For many living in low-income countries, care is often inaccessible and affordable. I'll never forget, I had a mother was from Cote d'Ivoire at one of my hearings on global autism, and she testified and said, I couldn't get any help for my son until she moved and migrated to Ohio, and then received a plethora of very good interventions, and her son was performing and doing very well. There is autism in their families are often socially isolated and stigmatized. Some communities attribute autism to witchcraft, which is horrible. The United States could play a vital role in supporting developing countries in addressing autism spectrum disorders by raising awareness, developing culturally appropriate screening tools, and training parents, teachers, and healthcare professionals on interventions so as to improve the lives of individuals with autism. Last Congress, I also introduced the Global Autism Act, which would establish a program within USAID. I hope to update that and reintroduce that in the next Congress, and hopefully we'll have some success there. Finally, our third very important topic of discussion will be on the issue of hydrocephalus. Hydrocephalus is a condition where fluid buildup in the brain leads to swelling of the head and serious brain damage that often ends in death. Hydrocephalus is a tragically common childhood condition. There are nearly 500,000 cases annually, perhaps many, many more. The most precious gifts in our society, our infants and young children, are the most vulnerable when it comes to hydrocephalus, and yet this condition also affects our elderly. Once again, hydrocephalus plagues infants in the developing countries. And again, we have a man here today who, Dr. Benjamin Wharf, who has been before our committee before, who developed an amazing procedure that has been applied in Uganda and throughout Africa. What doesn't require a stint, and it has just revolutionized the effort. And I'll never forget, we had a few of the doctors that he worked with, including indigenous Ugandans, who testified via remote as well as in person. And they said when the moms got their kids back, and you know the pain as well that is mitigated and ended through this, the flow of tears was just almost unimaginable. So Dr. Wharf, you have been a lifesaver. You all have been, but you have been a lifesaver when it comes to hydrocephalus. And we thank you, I thank you, we all thank you for the great work you have done. I will introduce our very, very fine group of individuals in a moment, but I would like to yield to Dr. Berra for any comments he might have.
Thank you, Mr. Chairman. And I know the ranking member, Ms. Wild, is tied up as ranking member in the Ethics Committee and will join us as soon as she can. I know she's got an opening statement. But again, thank you for holding this hearing on an incredibly important topic. I'm going to focus mostly on Alzheimer's disease with regards to brain health. As the chairman pointed out, the number of people living with Alzheimer's disease and dementia is projected to triple from over 55 million people today to more than 152 million by 2050. The cost of Alzheimer's disease and dementia to the global economy is $1.3 trillion in 2019, and it will continue to grow exponentially in the coming years as demographic transitions lead to an aging global population. And while the U.S. government has increased the domestic R&D budget on Alzheimer's at the NIH by tenfold over the last decade, from $400 million to $4 billion, there is currently no funding for global Alzheimer's and dementia programs at the global level. So as a doctor, I've seen acutely, and as an internist, I'm acutely aware of how Alzheimer's disease and dementia affect not only the patient, but also the impact it has on the caregivers and the family, and disproportionately, in many cases, affect the female population. In our district, we've held 9 annual brain health forums working with the local Alzheimer's Association to provide our constituents with information and resources on the latest Alzheimer's research and what is available to them to assist caregivers and persons living with Alzheimer's or other dementias. That said, however, nearly all Alzheimer's research has been conducted on Caucasian populations of Western European origin, leaving out 90% of the world, which has significantly limited progress. That's why today I introduced the bipartisan Global Alzheimer's Initiative Now, or the GAIN Act, alongside my co-leads, Representative Brian Fitzpatrick and Young Kim. The GAIN Act will authorize U.S. participation in and contributions to the Davos Alzheimer's Collaborative. The Davos Alzheimer's Collaborative, or DAC, was launched in 2021 as the first global alliance of governments, nonprofits, academia, and the private sector driving efforts to combat Alzheimer's disease. DAC aims to invest over $700 million over 6 years to link, scale, and build on existing efforts across every sector and foster an innovative ecosystem to coordinate and accelerate the pace of innovation in Alzheimer's disease research and care, and to improve brain health globally to achieve equitable and accessible health care. It's critical at this time that we leverage U.S. resources to most effectively combat this devastating disease for our constituents, their families, and individuals impacted by Alzheimer's disease and dementia around the world. Look forward to hearing the testimony, and again, thank you for holding this hearing. I yield back.
Is Ms. Manning coming back? Okay. Thank you. It's now my honor to introduce our very distinguished witnesses, beginning with Dr. Gladys Maestra, who's the director of the Rio Grande Valley Alzheimer's Disease Resource Center for Minority Aging Research. She is a physician scientist who has devoted much of her professional life to Alzheimer's research in low-resource settings. Her research has explored cultural, educational, and genetic risks for Alzheimer's disease and cognitive decline, as well as cognitive function and health among minorities and ethnically diverse populations. Dr. Maestro is also the co-director of the South Texas Alzheimer's Disease Resource Center, where she focuses on personalized medicine's approaches to improve prevention, treatment, and care for patients with Alzheimer's disease and related dementias. Dr. Benjamin Whorf is the founding chairman of NeuroKids, a nonprofit organization established in the year 2020 that exists to help children with hydrocephalus and spina bifida in low-resource countries. Dr. Whorf is also a professor of neurology at Harvard Medical School and director of neonatal and congenital anomalies neurosurgery at Boston Children's Hospital. He served as chief pediatric neurosurgery and director of surgical education at the University of Kentucky Medical Center in 2000, when he and his wife and 6 children moved to Uganda as a medical missionary with Cure International to be the founding medical director of a pediatric neurosurgery specialty hospital until 2006. While there, Dr. Whorf developed and validated a new endoscopic neurosurgical procedure to treat infant hydrocephalus, known as the ETV-CPC, and I'll leave it to you to say what that stands for. He is also the first to identify neonatal infection as the most common cause of infant hydrocephalus in East Africa. And again, has been before this committee several times and has been amazing with the leadership he has provided. Dr. Andy Shih is the Chief Science Officer at Autism Speaks, an organization we work very closely with on the Autism Caucus, and I want to thank him. Dr. Shih has led important advancements toward the organization's mission, including the development of several large international research consortia that delivered high-impact scientific outcomes for the community. He was central to the 2008 passage of the World Autism Awareness Day resolution at the UN, and subsequently led to the development of the Global Autism Public Health Initiative that provides technical support to country governments to enhance autism awareness, advocacy, and services worldwide. His leadership at Autism Speaks supports ministries, governments, agencies, and leading non-governmental organizations in more than 70 countries to deliver better outcomes. And of course, we all remember when the G20 adapted a very, very monumental, and they played such a role, you played such a role in it. So to have some, a change in direction to come up with something that will ameliorate autism by 2025, it was a very, very important pivot, and it helped us and all of us in countries, governments around the world to focus additional resources, saying we have a target date, let's try to achieve it. And then we have Dr. Yashuda Rana, who serves as the Associate Director for Research at the Eleanor Crook Foundation. In this role, Dr. Rana oversees ECF's multi-million-dollar portfolio of grants in maternal and child nutrition and provides thorough leadership both to the ECF team and its community of partners. She is currently a member of the Power of Nutrition's Technical Advisory Group and serves as a member of the editorial board of Maternal and Child Nutrition Journal. Prior to ECF, Dr. Rana was Associate Director at Results for Development, overseeing the nutrition team's data and learning practices. There, Dr. Rana Data Dent led it, I should say, a 5-year initiative aimed at strengthening the nutrition data value chain and informing the African Development Bank's nutrition strategy and costing and financial analyses. Thank you all for being here. The testimony you will provide will be incredibly useful going forward, as well as starting from today. Dr. Maestro.
Chairman Smith, Ranking Member Wild, I'm pretty sure she's going to look at this, Dr. Vera, distinguished members of the subcommittee, it is an honor to testify before you today. To harness the promise of science to mitigate the suffering of the millions experiencing Alzheimer's dementia across the globe, we need to advance scientific knowledge, but also design the infrastructure and resources required to make this promise a reality. A comprehensive, cohesive global agenda will allow our nation to leverage the momentum that the National Plan to Address Alzheimer's Disease Act, known as NAPA, and the Alzheimer's Accountability and Investment Act have facilitated. These bills were recently reauthorized with unanimous support in Congress. We are grateful to you, Chairman Smith, and all members of the Congress who have championed and continue to support this bill, and Dr. Vera for that initiative on the GLADMAT. As a result of these investments, seminal advances were made in diagnosing and treating Alzheimer's disease. For example, we now know that Alzheimer's begins 20 years or earlier before memory loss or other symptoms develop. And in unprecedented move, the FDA approved 2 treatments that can modify some changes in the brain of Alzheimer's dementia patients. We are moving toward incorporating biomarker detection for Alzheimer's disease into routine preventive health care. Even though many aspects still need to be clarified, we can now detect brain changes in vivo by measuring cerebrospinal fluid and plasma molecules. We refer to these molecules as biomarkers, and they may function similarly to prostate-specific antigens, PSA, where elevated levels prompt further assessments to rule out disease. Our global brain health agenda needs to be cohesive and should take advantage of the momentum and consider the following facts. First, Africa, the most genetically diverse continent, offers a vast yet underutilized resource for studying how genetic and environmental factors contribute to chronic and infectious diseases. While the African diaspora in the US is growing, it represents a fraction of the genetic diversity found on the continent. Second, the risk factors affecting every brain disease vary across ethnic groups due to genetic and cultural differences. However, most studies focus on European populations, limiting their applicability to other groups. For instance, ApoE, the most common genetic risk factor for Alzheimer's in Europeans, has minimal impact on African American or Hispanics. Third, without the knowledge of disease etiology in the ancestral source populations, our ability to fully address the needs of African Americans, who are also experiencing a rise in life expectancy, remains limited. China and the US compete for a strategic influence in Africa and Latin America. Increased US investment in health research and infrastructure offers a strategic, cost-effective way to counter China's advance and rebuild trust in the global South. One example of this that we have done in Latin America is the Maracaibo aging study in Venezuela. Despite efforts to move from projects to a cohesive strategy, brain health, especially Alzheimer's, still lacks a clear global agenda. I urge you to consider a global strategy to advance Alzheimer's research that benefits our people in America and it strengthens the US position in Africa and other low and middle income regions. This approach may leverage NIH-funded programs that combine research training with community engagement, such as the Resource Centers for Minority Aging Research, the RECMARS, and the Alzheimer's Disease Research Centers, ADRCs, and the Diversity Centers for Genomic Research. partnership with Alzheimer associations and other patient advocacy groups, as well as professional societies like the Gerontological Society of America, are instrumental in implementing a concerted agenda. Finally, we must develop a pipeline of experts in both brain health and foreign affairs. With over 250 North American universities offering global health education, we have the means to do that. Thank you very much for the opportunity to testify today. I look forward to answering any questions you may have.
Thank you very much, Doctor, and your very, very lengthy and scholarly testimony will be made a part of the record, and all of your, and any other extraneous material you want to include in the record. Dr. Worf.
Thank you, Mr. Chairman and Dr. Berra and other members that will be listening. Thank you for this invitation. It's an honor, as always. And thank you, Mr. Chairman, in particular for your commitment and support over the last many years now. It's very valuable and very much appreciated. Hydrocephalus is a common childhood condition that can be devastating or even fatal. The good news is that it's treatable. The bad news is that children in much of the world either get suboptimal treatment or no treatment at all. The normal brain contains fluid-filled spaces called ventricles that communicate with the fluid space outside the brain. Anything that disrupts this circulation can cause the fluid called CSF, or cerebrospinal fluid, to accumulate within the ventricles, which then enlarge under pressure. That's hydrocephalus. There are many causes of hydrocephalus. Some cases are congenital, and others are secondary to another condition. In resource-poor countries, the two most common causes are neonatal infection and neural tube defects, commonly referred to as spina bifida. Together, these account for about 2/3 of all causes of hydrocephalus in the developing world. Thus, a great deal of hydrocephalus could be prevented by reducing the incidence of newborn infections and spina bifida. Hydrocephalus is the most common condition treated by pediatric neurosurgeons, with close to 1/2 million new cases per year. But it's tragically most common among those children who have the least access to treatment. The incidence of congenital hydrocephalus is highest in Africa and Latin America, and it's lowest in the United States and Canada. When you include cases related to neonatal infection and neural tube defects, the annual case volume in resource-poor countries is more than 20 times that for high-income countries. 3/4 of the world's case volume of childhood hydrocephalus can be found in Latin America, Africa, and Southeast Asia. Infant hydrocephalus, whatever its cause, results in expansion of the brain's ventricles, which stretch and compress the surrounding brain tissue, causing mechanical injury and decreased blood flow. The head enlarges dramatically, and the child suffers from progressive symptoms, and about half will die without treatment within 2 years. Survivors typically have severe neurocognitive disabilities and spasticity and blindness. Untreated hydrocephalus is also costly. The estimated annual economic burden of untreated infant hydrocephalus in sub-Saharan Africa is between 1.4 and 56 billion US dollars per year using the value of a statistical life method. The estimated benefit to cost ratio for treatment is more than 7-to-1, which is more than some of the other interventions that are more commonly performed. The standard and most widely practiced treatment for infant hydrocephalus is to implant a tube called a shunt that allows CSF to escape from the brain's ventricles to the abdominal cavity. But 60% of shunts will have failed at least once within the first 4 years, and the risk of failure, which can be life-threatening, never ends. A minimally invasive endoscopic brain operation called ETV-CPC, which stands for endoscopic third ventriculostomy and choroid plexus cauterization, which is why we call it ETV-CPC, can permanently treat infant hydrocephalus without the need for a shunt in around 2 out of 3 infants, and has been shown at least as effective and safe as shunts, and with a far lower risk of infection. But unlike shunts that can fail repeatedly over a lifetime, virtually no ETV-CPC treatment failures will occur after the first 6 months. It's notable that this procedure was originally developed and validated in Uganda with the support of funding from both USAID and NIH. Its subsequent adoption by major pediatric centers here in the U.S. demonstrates how federal funding of projects abroad can benefit U.S. citizens. Countries with the highest volume of hydrocephalus have the fewest neurosurgeons, with around 330 pediatric neurosurgeons caring for a population of 1.2 billion children in low-resource countries, where shunt dependence is more dangerous. Children with shunt failure and no access to emergency surgery often die. Therefore, training and equipping these neurosurgeons to perform this procedure will substantially reduce the number of shunts placed and save lives, while also reducing the number of repeated shunt operations on an overburdened neurosurgical workforce. NeuroKids is a nonprofit organization that uniquely focuses on training and equipping these neurosurgeons to perform ETV-CPC, using a combination of on-site training in their home institution and subsequent remote mentoring that employs virtual presence technology during surgery. We prioritize partnerships with neurosurgeons in high-volume referral centers and subsequently leverage their training by adding them to our growing international team of neurosurgical mentors. NeuroKids currently works with partner sites in 13 countries of Latin America, Africa, the Middle East, and Southeast Asia. In conclusion, more funding is needed to accelerate the elimination of untreated pediatric hydrocephalus and to minimize life-threatening shunt dependence in low-resource countries, thus saving the lives of countless children. As well, public health strategies that reduce neonatal infection and neural tube defects would substantially reduce the number of children throughout the world who are affected by this condition. Thank you again for the opportunity of being here.
Thank you, Dr. Worf. Thank you so very much for your leadership and for being here. Dr. Scher.
Thank you, Chairman Smith, Ranking Member Wild, and all distinguished members of the subcommittee for inviting me to testify and for holding this important hearing. I'm Dr. Andy Scher, Chief Science Officer at Autism Speaks, a national not-for-profit organization dedicated to creating an inclusive world for people with autism throughout their lifespan. We do this through advocacy, services, support, research, and innovation, and advances in care. In addition to the work we engage in domestically, Autism Speaks has been committed for many years to developing and implementing strategies and programs that positively impact the lives of people with autism, other developmental disability around the world. The primary vehicle for this has been our Global Autism Public Health Initiative, also known as GAF. GAF is a community participatory research and advocacy program where, in addition to facilitating high-impact science to inform program and policy development, we serve as technical advisor to governments and NGOs committed to enhancing support for our community. We help source expertise, support community-based knowledge co-production, and facilitate dissemination and implementation of sustainable solutions. What we learned from our many years of work in the space and through our Autism Leadership Network, a distinguished group of leading international autism advocates that Autism Speaks has supported for over a decade, is that there are some absolutely incredible individuals and organizations working in countries across the globe to raise awareness of autism and increase access to services. These are truly some of the most remarkable, caring people you will ever meet, often work with extremely limited resources in difficult political climates. What we also learn is that while these advocates have made a significant impact, we've only scratched the surface in terms of building the awareness and acceptance of autism and infrastructure for services that are needed around the globe to meet the needs of autistic people. Much of the work that's engaged internationally involving working directly with community organizations. Last year, we had the opportunity to collaborate with the World Health Organization and UNICEF on a first of its kind report, the Global Report on Children with Developmental Disability. This report provides a comprehensive perspective on the prevalence and characteristics of children with developmental disability globally and serve as a call to action for all nations. I'd like to focus on a few of the findings and recommendations from this report, as I think they are helpful for informing our conversation today. First, the report notes that there are an estimated 317 million children and adolescents worldwide who have health conditions that contribute to developmental disabilities, and 95% have no access to appropriate care at all. Children and adolescents with developmental disability are at increased risk for mental health conditions and premature death due to illnesses such as obesity, diabetes, heart and respiratory diseases. Their needs are largely neglected, and they continue to experience stigmatization, prejudice, institutionalization, and barriers to participation, as well as social, economic, educational, and other forms of exclusion. And barriers in access to care, along with poor quality of care when compared with their peers, this result in widespread inequities in terms of health outcomes and, tragically, premature mortality for many people with developmental disabilities. Despite the depth of these challenges, this report provides hopes and a path forward. The overarching objective of this report is to take action for change. Children with developmental disability and their families have long been neglected to the margins, and that has to change. That has to change now. This report maps out 10 action areas to accelerate change in policies and care systems for children and young people with developmental disabilities. I encourage all members of the subcommittee to read through them. One key takeaway from the report is that improving health outcomes for those children must involve a holistic approach. To truly make progress, institutional barriers to care must be addressed. At the same time, more personalized approaches must be utilized to address each child's individual needs. To accomplish this, one approach known as the step care model is being increasingly recognized as an efficient and effective way to build a tiered system of care for children with developmental disability. This approach involves making available care options of varying levels of intensity linked through defined care systems. Recently, Autism Speak implemented the step care approach by supporting UNICEF pilot that focused on early identification intervention for children with developmental delays in 3 countries, Bulgaria, Peru, and Uganda, as part of the Care for Child Development Initiative. The work being done in these countries is already having substantial impact, and the Global Report on Children with Developmental Disability will continue to serve as a rallying point, as well as a roadmap to make progress around the world. Lastly, while millions of people with developmental disability around the world still struggle to access appropriate care, health care, I'd like to acknowledge the progress that's been made in the development of tools to improve autism diagnosis. Autism Speak supports the development of 2 freely available tools: the open source screening and diagnostic tool, which is called OSSDX for autism spectrum disorder, and the Nigerian Autism Screening Questionnaire. The ability to reliably screen and diagnose autism is critical in determining the most appropriate level of care for autistic children. High-quality screening tools like these are necessary to address the challenges in improving diagnosis and intervention. Chairman Smith, throughout your career, you have been an incredible champion for autistic people, not just here in the United States, but around the world. If passed, the Global Autism Act that you had previously proposed will be a tremendous step in the right direction in helping to address some of the challenges I mentioned today. I'm grateful to you for inviting me to testify at this particular hearing, where we're focused on the neglected aspect of public health. People with autism and other developmental disability around the world have tragically been neglected for many years across every system of care. As I said earlier, the time for change is now. I look forward to working with you and all members of the subcommittee in making that change. Thank you again. I look forward to your questions.
Mr. Chair, thank you so very much, and thank you for the great work. Autism, for the great work that you have done at Autism Speaks. It's just incredible. Matter of fact, in 2005, when the autism bill was going to die because of House inaction. It was Autism Speaks that saved it. And so I'll never forget that. So deeply appreciate it.
Thank you, Chairman Smith.
Let me now turn to Dr. Rana for your comments.
Chairman Smith, Ranking Member Wild, Representative Manning, thank you for the opportunity to discuss the critical role of combating malnutrition in promoting global brain health. Thank you to Chairman Smith and Ranking Member Wild for your leadership in the fight against child malnutrition. I serve as the Associate Director of Research at the Eleanor Cook Foundation, or ECF, a US-based philanthropy solely focused on ending malnutrition. I manage a multi-million-dollar portfolio of grants that is focused on child and maternal nutrition. Today, I will summarize my written statement in 3 key points. First, malnutrition is harming the brain health of children worldwide. Second, the crisis of malnutrition is detrimental not only to children and their families, but entire nations and economies. And third, malnutrition is a solvable crisis. We have cost-effective solutions ready to be scaled today. To my first point, malnutrition is a leading cause of child death, and children who survive face stunted growth and cognitive impairment. As we all know, brain development begins during pregnancy. By the 4th week, a fetus has 10,000 brain cells, and by the 24th week, this number expands to 10 billion. In fact, by age 3, a child's brain is about 80% the size of an adult's brain. The importance of proper nutrition during these early years cannot be overstated. Malnourished mothers are more likely to give birth to children who are too small or born too soon. And these vulnerable babies are likely to have worse neurodevelopment and cognitive outcomes, and also are at a serious risk of illness and even death. This brings me to my second point. The harmful effects of malnutrition on brain health extend beyond individuals to entire nations and economies. As President Adesina of the African Development Bank frequently says, the greatest contributor to economic growth is not physical infrastructure, it's brain power, what he calls as gray matter infrastructure. Individuals who face childhood hunger earn 10% less over their lifetimes and are 33% less likely to escape poverty. The economic cost is huge. Malnutrition is estimated to result in an annual productivity loss of up to $3 trillion. But for all these dire statistics, there is hope, which brings me to my third point. Proven, cost-effective solutions to malnutrition exist and are ready to be scaled up. Take the solution of prenatal multivitamins for pregnant women that you can see here, which we call as MMS. This complete prenatal vitamin is considered as one of the best buys in global health. It not only protects the health of the mother, but it also prevents kids from being born too early or born too small. And we have studies showing that babies born too small have lower IQs than their counterparts. On a personal note, when I had my 2 pregnancies here in the United States, I took a prenatal multiple vitamin just like MMS because I knew I wanted my children to have the best start in life and I could access these supplements. But in low and middle income countries where the prevalence of malnutrition is much higher, pregnant women only get 2 nutrients, iron and folic acid. Another cost-effective solution is breastfeeding. Breast milk is nature's superfood that protects children's brain health, and it also protects the health of mothers and babies. Yet, only 41% of kids worldwide are exclusively breastfed. When breastfeeding moms are supported, they're twice as likely to continue to breastfeeding their children. Finally, despite global efforts to improve children's diet, there are still families that are still not able to meet the nutritional needs of infants. A food-based supplement here that I'm showing is designed specifically for vulnerable children, and it's called SQLNS. It's proven to save lives, it's proven to prevent malnutrition, and it contains the recommended intake of micronutrients as well as protein. I want to end my remarks by talking about the impact of US leadership. The US has historically been the largest donor in the fight against malnutrition. My birth country of Nepal offers a notable example of the benefits of this leadership. In 1995, Nepal had the highest stunting rate in the world. 7 out of 10 children had delayed growth. But over the past 20 years, with strong government leadership, policies, and donor support, specifically USAID's nutrition program, Suhara, Nepal has reduced stunting by half. And thanks to US government leadership, we've seen a historic surge in treatment for children with severe acute malnutrition. In 2023, an estimated 1.2 million children's lives were saved because of this treatment. This success highlights the critical role of bipartisan congressional support. But UNICEF recently reported that 1 in 4 children today is living in severe food poverty. That means 181 million children do not have the equal opportunity to grow, develop, and learn. That means 181 million minds are at risk of being wasted. It is not easy to comprehend a number so huge, but I urge you to remember that every one of that colossal figure stands for a child who deserves to have ambitions and who, with the right nutrition and care, can grow and prosper. We know that progress is possible, and now we must stay the course. Thank you, and I look forward to your questions.
Thank you so very much, Dr. Rana, for your testimony and leadership. Just a few opening questions. First of all, your testimonies just answer many of the questions that all of us might have had, so that is deeply appreciated. With regards to the 2013 G8 summit that was held, of course, for trying to find a disease-modifying or a cure for Alzheimer's. And I wonder if you could speak to how well or poorly we were doing on that timeline. NAPA did help us, and that was a total bipartisan effort to have a strategy to quadruple the amount of money that's going towards, most of it to NIH in the area of Alzheimer's research. But if you could speak to, as 2025 rolls around, and of course the SDGs also speaks to health in a variety of ways, including in the dementia realm, if you could speak to that. Secondly, I would say, and ask Dr. Worf, when you testified in the past, not only have you pioneered and helped save countless lives with your intervention, the non-stunt intervention, you had spoken of the effort to train Ugandans and Africans at Cure International and other initiatives to be the neurologists, to be the surgeons, to be the brain health experts. And I'm wondering if you could update us on how well that might be doing, whether or not it needs a major push, and any estimate on how many. I mean, I remember you showed us pictures of kids in Uganda who, before and after they, they're unfortunately, the fact that their brains had so swelled up, and the after pictures with their parents with smiles from ear to ear because they had been cured. If you could speak to that, and again, further elaborate briefly, if you would, on the issue of the infection-based, because we had a lot of people. I chair the Spina Bifida caucus as well here in the House, and it's completely different. We know, interventions in utero can help mitigate the impact of spina bifida, but you pointed out, and you had experts to verify this was infections-based. Because when I went and spoke, as I do every time, Samantha Power, Mark Green, all the USAID administrators are all wonderful people. They always say, well, we're dealing with infectious diseases. They do not want to cross that line into global brain health. That's why my bill has failed at the launching pad every year. It's not going to fail this coming year. I'm just, and your testimonies and your help will help make that happen. I mean, why aren't we doing this? And so many people are so malaffected by it. Yes, HHS does some good work, but it's mostly in the realm of diplomacy, health diplomacy, not funding projects, NGOs and the like to take all of the global brain health initiatives on. With regards to autism, just a brief little story. I was in Abuja and then went over to Lagos in the year 2000. It was on a combating human trafficking trip. And I spoke to about 500 people, and the man came up and he says, "What are you doing about autism here?" Nothing. So I went, had lunch with him, breakfast, I should say, and we had a great meeting. And I know you guys do a great work internationally, and I thank you for that. But again, we need to make sure that our government is doing more, which is why this initiative, I think, just has to be. And I do think we can succeed. And Dr. Rana, if I could, with you, I'm a great believer in the first 1,000 days from conception to the second birthday, food nutrition for the mom so that both mother and baby are as healthy as humanly possible. And we do know that folic acid, and this has come out of the research pursuant to the Autism Cares work, and that folic acid can, if taken very early in the pregnancy or by a woman of reproductive age as she becomes pregnant, it greatly reduces autism. Greatly reduces it. And so the more that initiative, ours and the UN's and others, can be shared with everybody, the better. But first 1,000 days, I remember I was in Guatemala the day they announced their cooperation with a first 1,000 days initiative, because they have a stunting problem, as does Nigeria and so many other places. And it works. Mothers healthier, babies healthier. I mean, it's the most crucial time health-wise in any of our lives. And it seems to me that, we need to be doing more. We have the Global Food Security Act. I was the House sponsor, got it passed twice. Went over to the Senate, it came back as a Senate bill. Who cares? It's a good bill. But are we doing enough when it comes to global food security? If you could speak to that. And you did mention folic acid, and thank you for bringing some of the other things that are so important. But if you could also, your presence here, your testimonies, it will be the gist of a brand new all-out effort to get the Global Brain Health Initiative enacted into law and to get as much by executive branch policy as possible, but also by statute. So I do ask you, if you could, speak to those issues and anything else you think we need to touch on. Gladys.
Thank you, Chairman Smith, for your question and your insights. So you asked me about the treatment and advances and how close are we to the cure. And I have to elaborate a little bit on this. We didn't know the situation was so complex for the brain as the brain ages. So we thought we were gonna have a patient with memory loss and dementia, and that we were gonna be able to treat it just like that. But we learned that it takes 20 years or more to get to the point of memory loss and other cognitive changes. So it takes 20 years. So we are now looking forward to therapeutics that will begin early enough to really stop the progression to the disease. That's our hope. With the current medications, which have been approved by FDA, they do work taking out of the brain one of the proteins that is deposited in the brain, that accumulates in the brain of people with dementia, which is the beta amyloid. So they do work. They are monoclonal antibodies. They get to the amyloid and they clean it. So if there is too much amyloid already, then there are going to be already other changes in the brain, like neuron death, deposition of other things. So it's not enough to cause a clinical improvement. Not too much. It delays few months, but it's not a cure. Are we closer? Yes. Are we there? No. So we are hoping that we are going to develop similar techniques and that we are going to develop strategies for different elements in the brain of people already with dementia, enough to at least stop the progression and maybe reverse. But what we are really hoping is to, once that we have the capability now to detect earlier, before the symptoms appear, that we are going to be able to develop therapeutics to stop right there, preventing the onset of the disease.
My turn. So I'll try to address each of your categories of questions. So first of all, you asked about, Mr. Chairman, the progress in training surgeons. And so the last time that I was here in this place was in 2011. And at the time, we had a training program on site in the hospital that we started in Uganda, where we brought neurosurgeons from other countries, developing countries, to train them there in this technique for a period of time, and then sent them back home, all right. And using, through that program, we actually trained neurosurgeons in about 30 different countries. There were challenges, though, with that, and one of those was that we were taking sometimes the only neurosurgeon in that region and taking them away from their practice for 2 or 3 months for training. They were being trained in an environment that was unlike the one they were going back to, and treating a different population of children. And sometimes there were obstacles to implementing their training when they got home. The pandemic sort of made us appreciate the role of remote presence teaching and technology. And around that time, we founded NeuroKids, which has a different paradigm of training. In this way, we identify partner neurosurgeons in needy places, high-volume centers that are seeing a lot of hydrocephalus, and we have a Zoom-based pre-site visit protocol. We do then a site visit and do hands-on intraoperative training. And then after the trainer goes back, what we're able to do is continue to mentor that surgeon through remote presence technology. For instance, I can sit at my desk in Boston, and in real time, with the screen, the video endoscope screen on my computer, I can talk to the surgeon, take them through what they're doing. I can telestrate on the screen, they can see that, and so we can virtually be there in the operating room with them. And that continues their training over a few months thereafter. In the last couple of years, we've been able to train in a number of sites in different countries, not just in sub-Saharan Africa, but also South America, Southeast Asia. And by the end of this year, we will have close to 20 different sites. And one of the strengths of this program is that we aim to train trainers. And so the person that we train, once they're competent, we support their mentoring and training of other surgeons in the region. So that helps us to scale this kind of work. In regard to the folate question, I won't speak a lot on that, but simply to say that because spina bifida, neural tube defects, is a major cause of hydrocephalus, preventing that is very important. And if when there is adequate folate supplementation or fortification of the grain supply, that has the potential to reduce the incidence of spina bifida in a country by about down to 2/3 of what it is. So it can make a significant impact on that condition. And then finally, in regard to the infectious origins of hydrocephalus, the pathogen causing that is largely unknown in most places in the world. Over the course of about the past 10 years and quite a bit of NIH funding, we finally were able to identify with the appropriate experts, not me, but we were able to, with leadership of Steve Schiff in particular, identify a new human pathogen that was actually causing the post-infectious hydrocephalus in eastern Uganda. It's a bacteria called Paenibacillus. And that hadn't been known to be a pathogen in humans. And so the next stage will be learning how to better treat and prevent that particular infection. But we have no illusions that that's what's causing these infections elsewhere. And so what's needed is similar research programs to identify what's causing the infections in the neonates in other parts of the world. And then finally, one of the important interventions is simple public health intervention around perinatal care. In Uganda, for instance, most of the children were born at home in the village without professional help. They're in an environment where they're constantly exposed to mud and animal dung. And one of the practices was to place animal dung on the cut umbilical stump to staunch the bleeding after the baby was born. And so there are a lot of sort of simple things that could be done, but on a big scale in terms of advancing basic public health measures to prevent neonatal infection, which in low-income countries, neonatal infections are very, very common. We don't have that kind of burden here in the U.S. That's really a condition of poverty. Here in the U.S., one of the most common causes of hydrocephalus, if not the most common, is hemorrhage in the brain in prematurely born babies that are preserved and supported in our NICUs. That's a condition, post-hemorrhagic hydrocephalus of prematurity, which is really a condition of prosperity, you might say. We don't see that in the developing world because those children, those prematurely born babies, don't survive. Yeah, so I think hopefully that covers some of your questions. Thank you.
Thank you, Chairman Smith. I just wanted to sum up some reflection here. I think one of the previous time that I testified in front of the committee, maybe almost 10 years ago now, I remember at that time we focused on conversation around awareness and inclusion of our community. Part of the reason we did that is because there were no tools, right, and programs and policy that could really facilitate the inclusion of our community in society and system of care. But now that we have, what I mentioned in my testimony about this diagnostic and screening tool that we developed, like Nigerian autism screening tool, and OS, open source diagnostic tool that we developed in Sub-Saharan Africa, as well as the caregiver skill training program, early intervention program we developed with WHO. They're now available globally. So it's no longer a question of what to do, but how quickly can we do it, right? We have the tools now. We have the resources to make a change happen. So it's become an implementation problem. And that's why with US's leadership, I think we can greatly accelerate the implementation process and bring a better tomorrow to all of our community around the world. Thank you, Chairman Smith.
Thank you for the question, Chairman Smith. I just wanted to start by appreciating both the chair and ranking member for passing the Global Malnutrition Prevention and Treatment Act and for really codifying the approach of focusing on evidence-based, cost-effective interventions. In my testimony, I mentioned U.S. leadership in scaling treatment for severe acute malnutrition, which you all might know more commonly as PlumpyNet or RUTF. Because of bipartisan support from Congress and USAID, RUTF was accessed by nearly 9.3 million children, saving 1.2 million lives in 2023. And I'm sharing this success story as a proof that when we focus on high-impact, cost-effective solutions and become razor-focused, impact is possible. And this is what we're hoping to do with these improved prenatal supplements. They also contain folic acid, but the case is we have a solution, but we still need to figure out how to deliver it. And the challenges can be multiple. Women not coming to antenatal care on time. So if the folic acid is not taken in the early stages of pregnancy, it's not going to work the magic that we need to. Women could be coming to antenatal care, but might not be able to afford or access these prenatal supplements. They might not be getting counseled on the importance of these supplements, and there could also be misconception or other adherence-related issues. So we have a solution, but there is still a lot of work to be done in order to deliver it to get to impact. For this reason, our foundation, along with 3 other philanthropies, has developed a roadmap for how we can reach women in the 45 high-burden countries with these improved prenatal supplements. So over the next 6 years, with an investment of $1.1 billion, we aim to reach nearly 260 million women with these improved prenatal supplements, which has the potential to save nearly 600,000 lives and prevent 5 million vulnerable births. And these births are at risk for also having impaired brain health. Thank you.
Thank you. Ms. Manning.
Thank you. Thank you to my good friend, Chairman Chris Smith, and also to my good friend Susan Wild, who is at another meeting right now. It has been a real honor to work with you on this subcommittee. Let me just say how much I will miss this work in the future. To our witnesses, thank you so much for your testimony today. You have given us wonderful examples of what can be done to help prevent or treat devastating brain and health issues with the right tools, training, and resources from the U.S. So, Dr. Worf, I want to ask you a question first. The President-elect plans to establish a Department of Government Efficiency to cut government spending. Do you believe that cuts to medical research should be on the table? And would reducing funding to entities like NIH, CDC, CMS, HHS hurt efforts to find the kinds of tools you've described, or cures or treatments, I should say, for diseases like Alzheimer's?
Well, thank you for that question. I of course think that reducing support for the entities that you described would be harmful to the health of children in most of the world. I also think, and this is partly in reference to what my colleague to the right of me here pointed out, in my opinion, for what it's worth, when the U.S. invests in helping other people in other countries, we show our best side. And I think few things could be more valuable to diplomacy. Not that I know anything about that, but that's my humble opinion. Is I think we need to show our best, which is caring about the rest of the world and being willing to invest and help them, because it, in a sense, if we want to look at it from a selfish way, that does come back to help us as well.
Thank you for that. Dr. Maestro, would you like to comment on that as well?
Sure. Thank you very much, Representative Manning, for coming here today and for these thoughtful questions. I like efficiency. I like to do things better. So I can only be hopeful that the advantages of research and over just trade and aid will come up. So I don't think that I hope, right, that the funding will only keep increasing and being redirected to the needs and where we have a chance to be more impactful. Alzheimer's disease, without doubt, we are at a moment where we need to take advantage of where we are and what we can do at the global level.
So in 2023, the NIH announced a $3 million in funding for Alzheimer's research, a collaboration between the U.S. and countries in Africa. Can you share just a little bit about what the impact of funding for programs like that can do?
The main success is that we have access to resources that we don't have in our nation. And that's at least, to mention one of them, is DNA, the diversity, the genetic and genomic diversity that we don't have. So, and this implies that we have access to cures, to targets that we don't have now. And that it's the leadership that we need in the world. We need to have access to resources in ways that we can use them right away because we have the technology, we have the infrastructure, and we have the desire. I also want to mention that we have, I think, a secret weapon, which is not as secret, which is the African American scientists. I think they are very eager to work even more with African scientists and the African community. So I think that we have a lot of pieces to really accelerate the discoveries that we need to bring back home, but also to make stronger partnerships in Africa and in other low and middle income countries.
Thank you. Dr. Schur, the president-elect's nominee to be the Secretary of Health and Human Services, Robert F. Kennedy Jr., said in a 2023 Fox News interview the following. He said, "I do believe that autism does come from vaccines." As a doctor, do you agree with him?
Thank you for that question, Representative Manning. So there have been numerous studies that have been done both in the U.S. and around the world to look at the causal link between autism and vaccine. And today, there has been no established evidence that link the two vaccination with autism. So, it is a settled scientific question.
I'm sorry, can you say that again, please?
It's a settled scientific question for the research community.
That vaccines do not cause autism.
That's correct.
Are you at all concerned about the potential head of HHS who might hold these views?
We have worked successfully with both parties over the years to advance the interests of our community, the well-being of our community, and we strongly believe that we're able to continue to do so.
I have heard some discussion about the fact that people believe that autism is on the rise. You described, I think in your testimony, some of the tools, better ability to diagnose autism. So do you believe autism is on the rise, or are we better able to diagnose autism, which gives higher numbers?
So certainly we're diagnosing autism more than ever before in history. And certainly part of the reason that we're able to do that has been an improvement in knowledge, right, and awareness, the efficacy of clinicians and so on, the tools that we have to assist in these processes. But I think there's still uncertainties. We know that autism is the result of genetic environmental factors interaction. We have some understanding of the genetic factors that are at play. We're beginning to understand what environmental factors are at play. So I think over time, we'll have a better understanding on what are all the factors that are really contributing to these conditions.
And when you say over time, will it just occur, or would investment in more research be helpful?
Absolutely invest in more research.
Thank you. Individuals with autism are far more likely than their peers to suffer from social isolation, exclusion, mental health conditions such as depression and anxiety. How can we help, first of all, reduce the stigmas around autism, but second, try to address some of those issues?
Yeah, that's an excellent question. So I think, first of all, awareness, right? And not only about awareness about autism, but really advocating for acceptance and understanding of autism, I think is crucial to make progress in the particular area. And I think the second thing is to really try to create accommodations for autistic people and their loved ones in our community, so they can be actively, intentionally included in family life, in social life, and so on and so forth.
And gainfully employed?
Absolutely. That is so crucial, right? Because by addressing all these social determinants that can lead to better health, we can actually improve the well-being and outcome of our community overall.
Wonderful. I have a question from my colleague who won't be able to make it here. Dr. Schur, in your written testimony, you highlighted your collaboration with the World Health Organization and UNICEF to help publish the first global report on children with developmental disabilities. How important are multilateral institutions, including the WHO and UNICEF, in supporting global autism and health research initiatives?
I think it's very important because obviously as an organization, we're limited in our reach and ability to influence programs and policy. But by collaborating with national organizations like WHO, UNICEF, it allows us to expand our reach and further disseminate sustainable solutions to community in need.
Thank you. Dr. Rana, thank you for holding up some of those very small packages of items that can have just a huge impact on the health of children and the nutrition that for families. Can you tell us what aspects of U.S. global nutrition assistance programs have proven the most effective, and also which have proven the least effective?
Thank you, Representative Manning, for your question. The ones that have proven most effective, in my perspective, have been the ones that have focused on cost-effective solutions, having a razor focused on really upping the coverage of these interventions that we know works. It's a strategy that we have these solutions, but we haven't still figured out how to scale them at high coverage so that every woman everywhere and babies are able to access them. On what has not worked is a question I'd like to follow up with a written response because I haven't seen the entire portfolio of programs, and it wouldn't be right for me to right now make a commentary on that.
Thank you. I think that would be helpful because we do talk about wanting to make sure that we're putting our efforts in the right place, and I agree we want to be efficient and effective. So sometimes it's as important not just to know what does work, but what's not working, what we should stop doing so that we can devote our resources to the things that are working. I had another question here. How can, Dr. Rana, how can global health partnerships help feed children with neurodevelopmental needs in malnutrition-prone regions? How can we be partnering? We had a bill on the floor that we were discussing earlier today about the war in Sudan and how 14 million people have been impacted by that war, either relocated or put in devastating circumstances where they are at risk of malnutrition. How can we be partnering to address some of the nutritional needs that are affecting people in such difficult circumstances?
Thank you again for that thoughtful question, Representative Manning, especially as there are multiple crises worldwide that are happening simultaneously, and the people who bear the biggest brunt are pregnant women and young children, what you, Chairman Smith, called precious, precious to our society. We have, again, these cost-effective solutions. If you look at the packet of ready-to-use therapeutic food, it is specifically for kids who are severely malnourished. Given their condition, taking a normal meal is not going to be easy for them. And so this provides them with the required nutrition for their treatment. SQLNS that I talked about is also from a prevention angle of how do we get kids early on before they get too wasted. And similarly for pregnant women, we are talking about solutions like prenatal vitamins that are more holistic, but also in some cases when women are very undernourished, we are looking at supplements for lactating and pregnant women also. So there are solutions that are feasible, that are possible. But then the challenge, again, is financing. How do we finance given the scale at which these crises are happening? And how do we reach these populations, which some of the UN agencies like UNICEF and WFP, they have baskets of food and services for both pregnant and vulnerable populations.
Thank you. Well, let me just thank you all for the work, the really important work you do. Thank you for being here today. My sister specializes in treating Alzheimer's patients at the UVA Medical School, so I am well aware of how devastating Alzheimer's can be for patients and families, how desperate they are for treatments that work either to arrest or prevent the disease from developing. So I hope we continue to invest in the research and the great organizations and great researchers who can provide solutions and treatments for all of the diseases that we've been talking about today, and that we continue to share our knowledges and our resources with the areas of the world that are most prone to having these problems, where our small amount of health can provide an enormous benefit. And not only do we help them, but Dr. Worf, as you suggested, it also helps us in our standing in a world where there is great power competition right now. And it's a good, effective way for us to build friends and alliances. So thank you. With that, I yield back.
Thank you very much. You know, if I could just recognize Scott Badish, who's now on my staff. 10 years as president of Autism Society and has been very helpful. And as we write this new bill with all of the groups, and Stuart, great to see you again, as always. We miss you already. He just retired in September and did a wonderful job in the Autism Cares legislation, and I want to thank you especially for that. But as we go forward, this is going to be an all-out push, and I think we can succeed. I mean, you have your testimonies, but your work, your life work is so important. You have saved so many lives and can enhance the lives of so many others to improve the quality of life. It's just extraordinary. So thank you for that. I do have just one brief question to Dr. Scher about the, I remember when thimerosal was all the rage, and of course that's been out of our immunizations for quite some time, and some people still cling to that, but it's not there anymore. So how can you be suffering from that and contributing to autism? And one of my first amendments I offered here as a new second-term member of Congress was to provide $50 million for the Child Survival Fund. It passed, it became law, and it was for one of the pillars of the Child Survival Fund was immunizations. And I actually traveled to El Salvador and many of the Central American countries and then African countries later, but for days of tranquility, when the FMLN were fighting against Duarte's government, and they would stop all fighting to immunize the children against diphtheria, polio, pertussis, the leading killers of children. So I do believe that there's an absolute important role to be played. But there is an argument made, and I would appreciate your thoughts on this, that if too many vaccinations are given at once, that could have a negative impact, maybe contributing to autism, but could have a negative impact on that child because of the absorption capacity of a very young child. You get 5 immunizations at once. What does that do? Does it, so spreading them out might be a wise and prudent course of action for mothers. I just wonder what your thoughts are on that. Get the vaccination, but spread it out.
Right, whether or not vaccinations should spread out. So this has been an issue in the community, as you know, for a couple of decades now. Certainly, there's no evidence that suggests that receiving multiple doses of vaccines a day leads to autism or is associated with autism. My understanding is that the developing child are able to tolerate this kind of vaccine schedule, right? And we have seen through history, this is not a new program that's been introduced. It's been around for decades. And, we certainly have not seen the evidence that this kind of vaccine schedule actually lead to significant harm for children's health.
I appreciate that. Let me just conclude. My hope is that your testimonies, the work you have done, builds on a renewed call to action to the incoming administration to really take on global brain health. And we'll do it by way of legislation. I do think we can get it passed this time. I've already spoken to some of the leadership, including the speaker, about this, that this is an idea whose time has come, to quote or paraphrase Victor Hugo, and you've been doing it. You all have been doing it, and we just need to do even more to make sure that USAID and not just HHS through diplomacy is embracing this achievable goal. So I want to thank you so much. Anything else you wanted to add now or by way of written submissions, please? Yes, Gladys.
Thank you very much, Chair Smith. I wanted to reaffirm, some of the comments you made. I have been devoted all my life to international work, and not only because I come from Venezuela and that my work has been in Africa and Latin America, but because now I work at the University of Texas, Rio Grande Valley, which is located in Brownsville, Texas. This is 10 minutes from the Rio Grande, from the river, and 40 minutes from SpaceX. Many of my patients and participants, when I talk to them, they mention the adversity of human trafficking in their lives. At least I would say that 20 to 25% of the women that I see as Alzheimer patients have been subjected to this type of abuse. And I wanted to lay that out because I think that the social determinants of health that we are experiencing in the border are in many ways related to what's happening in low and middle income countries, the lack of access and the new opportunities that we have now to bring together issues which you have led for many, many years, and now we can envision a global health strategy with these diseases and these strategies, but also to, that will benefit not only low and middle income countries, but low resource settings like the Rio Grande Valley in South Texas.
Thank you for that. Are you suggesting trauma-induced Alzheimer's? Is it because of beatings or because of sexual assault?
We believe that adversity of that level is increase the vulnerability of the brain to confront aging and to develop a healthy life.
Well, thank you for that. That bears us really focusing on that. Just for the record, I am the author of the Frederick Douglass Trafficking Victims Protection Prevention Act. Passed the House in February. It's still pending in the Senate. It's probably going to die in that dustbin called the United States Senate. It just kills me that it's just sitting there, and I've been calling, I've been asking, and it looks like it's going to die in the next 3 weeks. So we're going to reintroduce it, start it all over again. And the original TVPA, which I wrote in the year 2000, took 3 years to get enacted, and we didn't know until the very end whether or not it would be pocket vetoed or approved by the Clinton administration, and Clinton did sign it, thank God for that. But I mean, it's like, why isn't this a no-brainer and just do it? But that's an area that we need to look into. I have never heard that before, so I thank you. So thank you so much, and we look forward to all of your input on what the bill should further look like, and maybe you might consider a collaborative letter from your organizations to Trump. We could highlight it as well. I'll do one from members of Congress, and I'm sure I could get bipartisan signatures for it. Because we want to make sure there's no diminution of what we're focusing on. We don't want to see money stop going to Alzheimer's research or autism or all these other important initiatives. But I think we need to go big. And I thank you so very, very much. Hearing's adjourned.